Hello, my name is Virginia Winn, and I am an associate professor of obstetrics and gynecology at Stanford University. I am a placental biologist and run a lab studying preeclampsia pathogenesis. And what I'll be talking to today is later in life sequelae associated with pregnancy complications, focusing on hypertensive diseases of pregnancy and preeclampsia. I hope everyone's having a good morning and enjoying the session so far. So these are my disclosures, nothing particularly relevant to today's talk. And the objectives of today are to understand potential risks of later disease associated with hypertensive diseases of pregnancy, and we'll focus on cardiovascular disease, diabetes, renal disease, and dementia. Hopefully you'll have a good handle on cardiovascular risk factors and some recommended interventions and health planning with your patients who have developed hypertensive diseases in pregnancy. So to get everybody on the same page, I wanted to review this key manuscript where the diagnosis and nomenclature was clarified in 2013 by the task force from ACOG. So we're no longer using, and again emphasizing, not using pregnancy-induced hypertension as a nomenclature. The hypertensive diseases of pregnancy are categorized in one of the following: gestational hypertension, chronic hypertension, preeclampsia, preeclampsia with severe features, superimposed preeclampsia, and eclampsia. And I wanted to highlight some of the major changes that were in this report. I'm not going to be addressing the diagnosis and treatment of the different hypertensive in pregnancy, but I just want to make sure everybody is aware of this 2013 report. So preeclampsia traditionally was diagnosed by elevated blood pressure and proteinuria. As of 2013, preeclampsia can be diagnosed with the hypertension without proteinuria as long as there's some other evidence of end organ damage. And that includes thrombocytopenia, elevated LFTs, elevated creatinine, or symptomatology related to the disease process. Other changes are massive proteinuria, 5 grams, has been eliminated for consideration for a severe preeclampsia diagnosis. Growth restrictions no longer considered for diagnosis of severe preeclampsia. So essentially, it's either preeclampsia or preeclampsia with severe features. So mild preeclampsia is not part of the nomenclature anymore. And then there's also a renewed emphasis on recognition and treatment in the postpartum period with preeclampsia. But the emphasis today results from thinking about you've had a mother that has been diagnosed with a hypertensive disease of pregnancy. She's made it through labor and delivery and the immediate postpartum period. And typically we discharge with expectations of resolution of disease unless they have chronic hypertension. And the real question is, do we need to be thinking about her long-term health more than just expecting this resolution of disease? And there are numerous risk factors that overlap between preeclampsia and cardiovascular disease. So these include chronic hypertension, diabetes, obesity, insulin resistance, dyslipidemia, and systemic inflammation. And it's important to be thinking about these risk factors for cardiovascular disease. Because heart disease is one of the leading causes of death in women. 1 in 4 deaths is attributed specifically to coronary artery disease in women, and 1 in 2 deaths from all forms of cardiovascular disease. And this isn't just completely later life issues. Heart disease is the second leading cause of death for women 45 to 64, so just right after childbearing. Third leading cause of death in women 25 to 44. And cardiovascular disease kills almost twice as many women as all forms of cancer combined. So this is a major women's health issue, and there is a lot of overlap with the hypertensive diseases of pregnancy in terms of risk factors. So I think it's really helpful to be thinking about pregnancy as the tip of the iceberg for women's health, and how to think about this in related to the rest of her life. For gestational diabetes, I think we've done a good job of education about later development of diabetes. And we need to be thinking in the same framework with hypertensive diseases of pregnancy. So the associated risks with later disease include hypertension, 4-fold higher, cardiovascular disease, 2-fold higher, and higher, particularly if a woman has recurrent preeclampsia or developed it early in pregnancy. There's also an increased risk of asymptomatic heart failure or heart failure B, renal disease, diabetes, and more recent data is looking into connection with dementia. So what my goal is to go over some of the data just to highlight these associations, to provide some guidance in terms of preventative approaches, and end with some common sense recommendations. So cardiovascular disease, as I mentioned, is associated with a 2-fold increased risk, and it includes everything from coronary heart disease to myocardial infarction, mortality, stroke, and also heart failure and dilated cardiomyopathy. So I really like this data from paper by Behrens et al. That shows the cumulative incidence of chronic hypertension with age of first pregnancy and from normal tensive pregnancies or hypertensive disease pregnancies. And what you can see is that hypertension increases by maternal age over time. So that makes sense. So a 40-year-old at 50 has about a 7% risk of chronic hypertension if she had normal pregnancy. In contrast, if they had hypertensive disease of pregnancy, these risks are for every gestational age, maternal age increased, such that a decade after hypertensive disease in a 40-year-old has a 30% rate of chronic hypertension. And if you look at hypertension, the increased relative risk is typically reported in the 3 to 4 range. Coronary heart disease, 2-fold risk. Stroke, also around about a 2-fold risk. And these risks, when you look at recurrent preeclampsia or preeclampsia that presents earlier than term, the risks are actually higher. And this is from a systematic review and meta-analysis previously. In terms of the American Heart Association guidelines for cardiovascular disease prevention, pregnancy is now recognized as a risk factor for developing cardiovascular disease, and they recommend referral to a primary care provider or cardiologist so the woman can be monitored and picking up disease and control early. So the cardiovascular risk categories Our high risk is established disease, diabetes, chronic renal insufficiency, and Framingham risk greater than 20% from a cardiovascular risk assessment. And at risk are one or more of these cardiovascular risk factors, and that now includes preeclampsia, gestational diabetes, and hypertensive disease of pregnancy. Low optimal risk is no vascular disease and a healthy lifestyle. So when, I recently came across this probably is the most updated recommendation of primary prevention of cardiovascular disease in women that came out in 2020. This is a nice paper to look at and review. What's interesting here is what they noted while pregnancy complications are known as a risk factor. This as an independent risk factor in the calculators actually hasn't proven to be more predictive, and that these pregnancy complications are probably reflected in other risk factors in the calculators. So the recommended risk reduction options for women is breastfeeding, cessation of smoking, maintaining a good weight, following a heart-healthy diet, regular exercise, and consideration of baby aspirin and statins depending on one's level of risk. In terms of stroke prevention, the guidelines from the American Heart Association for woman is with a history of preeclampsia or eclampsia is to make sure that this is documented and follow for risk assessment 6 months to a year postpartum. And they commented back in 2014 that clinicians are often not aware of this association, meaning primary care physicians and cardiologists. So it is really key and important for those providing obstetrical care to educate and inform the woman's primary of the need for follow-up. So turning now to symptomatic heart failure and hypertensive disease of pregnancy, there has been a good amount of data showing an association between heart failure and hypertensive disease of pregnancy. In this paper by Jarvie et al., they looked at readmission of women after pregnancy for a admission specific to cardiovascular disease. And what they found was that readmission rates in normotensive population in pregnancy was 2.5 per 1,000, but hypertensive diseases of pregnancy was elevated at 6.4. They noted that there was a higher rate of readmission among African Americans, and the reason for readmission in 70 to 80% of these cases was due to heart failure. In a large insurance database study, they showed that risk of congestive heart failure, formerly, I have a typo, I think.
Dr. Winn, good morning.
Oh, preeclampsia, there we go. It's supposed to be an E. So those that had preeclampsia have an increased risk of congestive heart failure with a hazard ratio of 9.1, and eclampsia had a hazard ratio of 7.1. And these increased particularly at 3 and 10 years after the index pregnancy. In a retrospective study, they saw similar types of results. What I'd like to do now is actually go over the definition.
Good morning, Dr. Winn. Good
Yes.
morning, it's Christina. Sorry to break in. I just want to let you know you're a little bit spotty at times. So
I am?
Things up with the internet, yeah. So just to let you know.
Should I go off video then?
Well, I'm wondering if that would help. Let's try another minute. I'm going to break in one more time if it continues, okay?
Okay.
Thank you.
I'm so sorry. All right. So heart failure is classified in 4 different stages. C and D are the symptomatic. Stage B is asymptomatic, where there are structural heart findings that are strongly associated with later heart failure. And in a study where they looked at rate of class B heart failure, what they found was that preeclampsia history had a higher odds ratio than even hypertension. And so I think we're learning more and more that preeclampsia really is giving us insight into women who are at risk, and that can be picked up earlier in pregnancy. And recommendations for reduction of heart failure risk is exercise, being on ACE inhibitors or ARB, beta blockers, and BNP to monitor heart failure. So again, really important that referral probably to a cardiologist or a primary care who is comfortable with this type of management. Now, moving on to diabetes, early studies showed that there was an association between development of diabetes and having gestational hypertension, mild preeclampsia, or severe preeclampsia, all relatively in the same hazard ratio. In contrast, hypertension is at higher levels. And you'll notice this is an older study using the older nomenclature. But there was a recent systematic review and meta-analysis that shows over many studies that have occurred since this study that the increased risk of diabetes is clearly around twofold risk. So it's not only about the cardiovascular system and diabetes, but what do we know about renal disease? Preeclampsia definitely impacts endothelial dysfunction in the glomerulus, and which is what results in the proteinuria. But what do we know about later renal function? So the glomerular filtration rate and the albumin creatinine ratio in the postpartum period has had kind of mixed results in terms of the studies. Some show increased need for renal function monitoring. Other studies have not showed any evidence of decreased filtration or microalbuminuria, while other studies have showed an increase of microalbuminuria. But what is shown in a number of studies is that there is a strong increased risk in end-stage renal disease. Fortunately, while this is a significant increased relative risk, the absolute risk is still low. And in terms of chronic kidney disease, there is some mixed data around this as well. what I want to share with you here is the data that shows a strong association with end-stage renal disease. And again, you'll notice that the numbers are low, but if you look years after a first birth, those with preeclampsia are in red versus the black, seeing a definite increased risk. If you look in women who've had 2 pregnancies, the risk of end-stage renal disease is predicted most strongly by the second pregnancy, or both pregnancies have the highest risk. If they had preeclampsia in the first pregnancy, but not in the second, it's still elevated, but not to the same degree. And you see that same pattern with increasing pregnancies. But for disease prior to getting to end-stage renal disease, I really like this study that highlights that looked at over 1 million women and broke it down by acute kidney disease and chronic kidney disease, as well as time of onset of the hypertensive disease of pregnancy. And what you can see is that there is some increase of acute kidney disease, but it's really the risk is more impacts related to chronic kidney disease. And the earlier onset, a higher risk. These authors went on further to actually break down the acute kidney disease into failure versus tubointerstitial nephritis. And what this highlights is that for acute kidney disease, it was only significantly associated in the term population, and the acute tubular interstitial nephritis was more associated in the earlier presentation. But again, the numbers are small, and for the most part, when you combine these all together, there was a non-significant association, as you saw, or very minimal increased risk. When you look at chronic kidney disease, what's interesting here is that overall, the risk is fairly similar regardless when you present. Hypertensive kidney disease is the highest risk with hypertensive disease of pregnancy, showing earlier having higher risk. For the chronic tubular interstitial nephritis, this was actually only seen in the earliest onset, and glomerular and proteinuric disease, again, very much showing a dose response in terms of earlier onset of hypertensive disease with development of glomerular or proteinuric disease. So I think key point here is, as more research is done, we begin to see specific diseases within these larger categories, and that we'll be able to become more attuned or sophisticated in terms of knowing what specific diseases to pay attention more in the early preterm or for all women who've developed hypertensive disease in pregnancy. So what do we know about the brain? So preeclampsia in some studies has been shown to be associated with cognitive function impairment, white matter lesions, and brain atrophy. And of particular interest is an association of the STOX1 gene, a particular SNP, is associated with preeclampsia and has also been associated with late onset Alzheimer's disease. But there are other studies who have not seen a link with early onset disease and possible vascular association or no association. And many of these studies were potentially underpowered to detect the outcome, as well as a lot of this is self-report and are complicated by recall bias as well as survival bias. So I think that one of the best recent papers is this paper by Bassett et al., where they looked at over 1 million women with from the Denmark database that is well curated, looking at women with a history of preeclampsia and then breaking it also down by the type of dementia, vascular, Alzheimer's, or other. And they did adjustments for many of the comorbidities. And what they saw was that it's really vascular dementia, which seems to be most strongly associated with preeclampsia. And that is even after adjusting for hypertension. And the small association they saw with Alzheimer's dementia could be explained by obesity in the sensitivity analysis, but the vascular dementia results persist. So conclusions and implications. There is a strong, robust association with studies that have been done over the last decade or more between preeclampsia, hypertensive disease in pregnancy, and cardiovascular disease, hypertension, diabetes, heart failure, particularly chronic hypertensive kidney disease, glomerular and proteinuric, and vascular dementia. And one of the questions that really comes up is this really women having a failed stress test of their physiology for these diseases that is being revealed in pregnancy as presenting with hypertensive disease of pregnancy? Or is there also an increasing changes in the mom because of the disease that increases their response to postpartum stressors and risk factors for later heart and health disease? So I think a rational approach for postpartum counseling and health planning for women with hypertensive disease and pregnancy is obviously checking blood pressure at the 6-week visit, educate patients about the risk factor of their hypertensive disease and the lifestyle recommendations that would go along with that. If they're going to become pregnant in the future, beginning baby aspirin at 12 weeks, and then have referral to a heart clinic, cardiologist, or primary care provider within 6 to 12 months, where they would be followed by blood pressures, weight, checking their cholesterol, considering other markers of cardiovascular disease. And again, recommending that they achieve healthful weight, exercise regularly, follow an American Heart diet, and quit smoking if they do smoke. And then they'll should have annual screening with cardiovascular disease risk assessment and medications as warranted. But most importantly, make sure that your patient knows their diagnosis the need for surveillance and communicating this to their primary or cardiologist. We are conducting a study at Stanford where we're bringing women back 2 to 12 years after having had a preeclamptic or normotensive pregnancy. And it is not unusual for the women who had preeclampsia not to know that they had it. And so I think that is probably one of the most important things, is making sure your patients are aware of their diagnosis and the implications of it. And then just wanted to kind of highlight, this is the American College cardiovascular disease risk calculator that puts in their current risk, and then if they optimize their lifestyle, what their risk will be in 10 years and lifelong risk. Most of these calculators actually do not have the pregnancy associated diseases in them. For cardiovascular disease, we know there's around a 2-fold increased risk. So typically, I would say just double the risk. However, that recent 2020 paper, I think, brings in that question, but the risk is probably, at least from the calculator, to 2-fold higher. They did mention that in younger women to emphasize it more. So I think, where are we going and how can we get to more personalized medicine? I think there is room for incorporation of preeclampsia into these risk calculators. Determine which women with preeclampsia are at greatest risk for the later sequelae, so we know who to follow most strongly. We also need to determine whether the health modifications that have been proven to benefit cardiovascular disease are just as effective or different for women with preeclampsia or hypertensive disease of pregnancy history. And work that we are working on is trying to understand the underlying biological link to help guide appropriate interventions for these women. So these are some nice key resources around this topic. And this is the set of references for the talk. And I'd be happy to answer questions.
Virginia, thank you again. It was a wonderful presentation. Thank you so much. We have some great questions coming in. And so one of the questions is there so if there's IUGR and preeclampsia, does the risk of cardiovascular disease increase?
Yes, that is a good question. So IUGR, even independent of preeclampsia, has been associated, shown in an association with increased cardiovascular disease. I can't recall off the top of my head whether there is a synergistic, or if people have looked at the combo. You would imagine that it could increase risk, and that may go along with the earlier onset of preeclampsia probably has a higher rate of associated intrauterine growth restriction. So that may be what's being picked up also in these epidemiologic studies of association.
Can you hear me, Dr. Winn?
I can.
Perfect, thank you. My internet's breaking up a little bit on my end, so I appreciate that.
Yeah, and while not all of the studies show, in terms of the anonymous attendees question, while not all of the studies have shown a increased risk based on gestational age at presentation and severity, I think the larger meta-analyses are holding up that association, that the earlier preterm, the relative risks in the meta-analysis are not as strong as some of the individual studies. But yes, I would be more concerned about a woman who presented early with severe disease for later cardiovascular disease. Any other questions? Oh, I see a few more. The risk of preeclampsia, even when they adjust for later onset hypertension or gestational diabetes, I'm not sure about the IUGR. The preeclampsia remains an independent association. Has there been any research that has looked at the correlation of ACES resulting in increased risk for hypertensive disease of pregnancy, since ACES has already shown an increase in cardiovascular later in life? I'm sorry, I'm not actually sure I know what that acronym is. If you could type in, spell out ACS. Yes.
There we go.
Oh, that's a good question. Do you find that there are any issues with insurance approval for cardiologist referral for preeclampsia? Yes, I think there is sometimes an insurance issue, but I can't fully speak to that. But I think given the increasing data, hopefully this will be corrected, and I would push for it. I would push back on the insurance carriers, because I think this is actually really important, because it is the #1 leading cause. And if we have an opportunity to instill prevention earlier, because of what pregnancy tells us about the woman's later health, I think this is really, really important. Who should follow up PE, OB, or nephrology? So I think in the immediate 6-week, it would definitely be the OB. I think cardiovascular is actually more important than the nephrology. That being because the overall incidence of the cardiovascular disease is so much higher, and a lot of what they will be monitoring will also pick up worsening renal disease. The actual rate of renal disease is lower than the cardiovascular disease. So I would personally argue for the most important follow-up is PCP who's comfortable with cardiovascular assessment, or a cardiologist.
Dr. Winn?
Yes.
I'd like you to speak to, it was very interesting. I'm sorry, I don't remember what the study was, or if it was a statement or a report, but you talked about, even at CMQCC, very important now with hemorrhage, where, the idea of risk factors and identifying risks. What about, it relates to care coordination, basically, because what you said is that OBs do not recognize this risk. And so therefore they're not counseling, or perhaps even keeping folks in care. So the importance of care coordination post-delivery for follow-up. Can you speak to that?
Yeah, I think that is one of the key messages here, is that as the obstetrics providers, it's really important that the woman knows the need for follow-up and surveillance, so she can be an advocate for herself, and then also really trying to communicate if the woman has a primary provider that's different than her obstetrician gynecologist, to make sure that the primary provider in the discharge summaries or handing off care at the end of the pregnancy are alerted to the importance of follow-up and surveillance. But I think this is an area that's probably it's not my area of research, but definitely quality improvement measures in this area, I think, can have a significant impact on women's health.
There's a great question about labetalol. So they have patients going home on labetalol and some in nifedipine. Does this really prevent long-term sequelae?
So women who are discharged on an antihypertensive following the pregnancy is really treatment in the acute period. Typically, those medications are not needed by the 6-week visit. So there isn't a current recommendation to be on antihypertensive other than needing, if it's needed, to keep the blood pressure. And now with actually the new American Heart Association, normal blood pressure range is 130/80. Many more people actually would benefit from an antihypertensive. And that's a whole nother discussion, because currently our diagnosis of preeclampsia is still 140/90, but that may be changing. But also realize that all of the current data looking at these later sequelae is using the current or former definitions of hypertensive disease in pregnancy.
Wonderful. Dr. Winn, there was a question earlier, and unfortunately I had to sign out of Zoom and come back in. Are you able to see it under answered or dismissed? I hate not to ask that question. It was actually one of the first questions that came in while you were speaking.
Under answered?
Either answered or dismissed.
Okay.
If you could look there.
Oh, I think that it is the left ventricular heart failure. It's definitely the left ventricular side that's seen in the heart failure B class with hypertensive disease of pregnancy. And then the dismissed. Related to, should OB/MDs counsel patients about exercise during and after pregnancy? Are there any exercise programs endorsed by ACOG? I have to admit, I don't know what the current, if there are any current programs endorsed by ACOG. Others in the group may know. Happy to share those answers with the group. Does insurance typically cover the cardiology consults postpartum? Again, obviously an important question. Some insurances I think have, but not all. But again, I would say this is something to advocate for the future. We have patients going home.
Yeah.
We answered
You know
that
what?
one.
You know what just came in? Should the OB, so should the obstetricians be checking, or midwives and PAs, be checking BNP on all preeclamptics?
No, I'm not aware of any recommendation for that within the context of pregnancy. That would be a consideration for the cardiologist in follow-up after pregnancy, depending on probably a number of risk factors and whether they see any heart failure be they meet any of the criteria for heart failure class B, so asymptomatic.
Got it.
Structural changes.
And then something about acute coronary syndrome in pregnancy.
Yeah, I am not a cardiologist, so I'm going to punt on that question.
How did you get this? I love hearing people's stories, if you don't mind. How did you develop this interest? I mean, I know so much of your research and background is,
Yeah. My real passion is the placenta.
There you go. Okay, speak to that.
Yeah, my real passion is the placenta. I'm fascinated by how critical and key the placenta and the placental biology is for normal pregnancy and also for obstetric complications, and particularly preeclampsia, because there's clearly a connection between the placenta and preeclampsia. When I was a PhD student, I spent many an hour culturing cells to get enough protein and enough RNA and DNA to perform my experiments. And when I went on my OBGYN rotation, never thought I'd be an OB. And I saw this beautiful organ just being dumped in the trash, and the amount of protein and RNA and DNA that was there. And the more I learned about how the placenta is a huge endocrine organ and how it's changing mom's physiology, I was hooked in trying to understand this organ and the complications that happen in pregnancy because of it.
Well, and then, before we take our break, what about, I know you're a member of Stanford's BioX, and can you speak to us a little bit about that? I know it's the Biosciences Institute, but what is your interest in that, or how does it all connect?
Yeah, the emphasis of BioX is to bring together scientists from different disciplines to address biology questions and health issues. So there's a lot of translational research, and it is a community of scientists that are interested in transdisciplinary science.
Got it. Okay. Well, I think we're going to wait another minute here to see if we have any other questions that come in. Otherwise, before we do that, I just want to remind everybody we've got a break coming up. And I think it's a great idea. So our next session is going to begin at 10:10 a.m. And I have to do a shout out for that because it's one historically for our potpourri conference that has been highly rated, highly loved every year. And that's the sharing of complex cases, both obstetrical and neonatal. So that will begin at 10:10. And we want to make sure that you're all back before then. All right. So I think, Dr. Winn, I'm not seeing anything else coming in. That was fabulous. And as a person who identifies as a woman, I have to tell you, thank you for caring for us for all our lives and throughout our lives. This is just, first of all, it's so cool. But second of all, thank you for caring. And we wish you well. And we're so grateful you joined us today.
My pleasure.
Take care, everybody. Dr. Winn, have a great day. We'll see everybody back, please, before 10:10. Bye-bye.